us and need to at some point really understand why we have got so many deaths. Next slide. So we have managed this situation. All of us have organised our departments. We've organised COVID areas and non-COVID areas. We've moved minors out. We've managed to finally steal that fracture clinic that we've all been after for 15 years. We've managed to expand our footprint into other areas. We've thought about where we put children. We've done the fight over PPE and made it recognise that the undifferentiated patient is a real risk. And we've done an incredible amount of work. But for most of us, now the COVID work is going down. And what we're seeing is that the other work is coming back. And if we again look at that syndromic data, which is fascinating data that is produced weekly, we can see that cardiac and AMI presentations are just back up to absolutely normal seasonal averages, which is good because those are the patients we were worried about. And things like gastroenteritis, people are not eating out in dodgy restaurants or doing, they're feeling that they can cope now with the D&V that they've had, which is great. Next slide. So we produced a position statement on the 6th of May, so just a couple of months after that last physical lecture, because we were worried that we could see that the patients were coming back into emergency departments, steadily coming back in, and we could not believe that anyone would think it was a good idea that we went back to the world that we were in at the beginning of the year, where things were really pretty desperate. So we put out these fundamental points, which was that we cannot be the reservoir of infection. We can't become crowded. And as a corollary of that, we must have hospitals that are not crowded. We must be able to provide vulnerable patients with a safe care experience. And we need actually departments to be safe places for work, for people to work in as well. We've got to be able to do that. So those principles are incredibly important. Next slide. And so we particularly said, these are the things that we need everybody to be thinking about. And by everybody, we mean ourselves. Everybody running a department needs to be thinking about this stuff. But very importantly, organizations, and then the management of the teams above that, and obviously going into, for you guys, for NHS England, but also all the other devolved nations as well. That these were the main areas that we needed everybody to be considering as we move forward, and all the language about resetting the NHS, rebuilding the NHS, restarting the NHS. Well, if we restart and we end up with crowded departments, we will be doing people harm. And I'm sure you've seen in the news real concerns about nosocomial infection in hospitals, potentially being new epicenters. And one of the reasons why the great R number isn't coming down as much as we would like it to do. So next slide. So infection control, we have to become absolute experts. Now, perhaps we should have been better than we were. We've all had to contact trace that measles outbreak, norovirus, managing flu this last winter. We've had to deal with all that. And this is an opportunity for us to deal with the risks of COVID, but actually maybe get a bit of a nosocomial dividend in reducing all the other infections that have actually been a problem for us. But because specifically we need to think about social distancing, we're going to have to think about maximum occupancy for each area. And we're going to need to think about how hospital capacity, in other words, how we get patients to beds, promotes good infection control. Next slide. And we cannot be crowded. We absolutely cannot be crowded. So there are patients that we need to be able to guarantee that we can manage them. They come into hospital and we can provide them a safe experience. Now, I can imagine nothing worse than a patient who has been social isolating, shielding themselves for 7 to 10 weeks. Then they get chest pain or they fall over and break a hip and they come into hospital and they pick up COVID. That would just be a disaster. So we need to know about these patients. We need them to be flagged to us as being a shielded patient. We need to have a bit more information. And I think the sooner we get joined up pre-hospital and in-hospital systems, the better. And there are great examples around the country, but there are also examples where all you get is 87-year-old collapse. And usually it turns out to be an 18-year-old of a different gender that actually turns up. So we've got to get that better. And we're thinking about how we, and I'm sure Cliff will talk about this more, demand management. In the past, we as a college have said, telling the public to stop coming to emergency departments has been unworkable. Unleash a global pandemic and it works. Seems a little bit of an exaggerated response to trying to get people to stay away from ED, but we can't argue that it's been an effective methodology for stopping people coming. But we need to now buy into people's acceptance that perhaps not just coming to hospital is a good idea, and make sure that 111 that was improved during this pandemic by having more clinical input, that is sustained, and we've got better routes of patients to either do self-care, go to the GP, video conference the GP, be referred in maybe to a hot clinic or same-day emergency care, or if they do need to come to the ED, we know about them and they're the right patients for us. And along with that crowding is the exit block part of this, which means delayed transfers of care being kept out. Next slide. And again, Cliff will show you a much more detailed version of this, but thinking about how people work their way through the system that keeps them as safe as possible. Next slide. One of the things I talked a lot about before the COVID was saying to specialties, you have patients that you know and love, that you give complicated treatments to, that have got chronic diseases that I can't even spell, and treatments that I definitely can't write on a prescription pad. You need to provide a route for their urgent care needs that doesn't involve them rocking up to the emergency department and me becoming a Rolodex for you. So find some way of being able to provide particularly urgent care needs as opposed to emergency care needs. I'm your woman if you want emergency care, but I'm not very good at giving advice for people who need to have something about their rheumatology drugs or their gastro drugs changed. But strangely enough, this is still part of, so this was part of A of cares. This is still something that absolutely has to happen. And this is where same-day emergency care may be very, very relevant. Next slide. And the other problem that we've got is so many of our departments are not physically in shape to deal with this endemic situation. We don't have side rooms, we don't have enough doored cubicles. Hospitals are not that great either. And there's been a lot of fantastic DIY that's been going on with a lot of plastic in the last few weeks. And people have done some very, very good arrangements. But you do worry that in 5 years' time, those plastic boards will still be there in the usual way of the NHS of putting up something temporary, which turns out to be actually what we get stuck with. But we need to think about our physical redesign, and anybody who's doing sort of rebuild, we need to think about how do we deal with contagion in general, COVID as just being part of that. Next slide.
Catherine, this is your 1 minute.
Thank you very much, Dee. And then the other part of this is going to be, how does testing fit into this? Because we don't really know very much about what the tests mean. But what we can't do is have patients who need to be tested and coming into hospital, ending up sitting in the ED, carrying on in the ED. And next slide. And so the final thing is that we want to get back to the discussions that we were having about the right metrics for emergency departments, because some of them were about reducing crowding. But we think that somewhere in there, we're going to have to think about maximum occupancies, and we're actually going to have some sort of infection control, the need to isolate being in there. So we can start thinking about that. And we're looking at getting some best practice guidance out there and starting thinking about how we can audit what that means. And next slide. We've got lots of challenges. There's a risk that the bed base in the hospital goes down because of social distancing of beds. We know that we're seeing the major ambulant patients coming back. And of course, we're all worried about what will happen with a second wave, which is predicted to be in around autumn as being the right time it comes. Next slide. So have an escalation plan. We're going to have to think about this, the maximum occupancy, and having an escalation plan, because we cannot go back to crowded departments more so than ever. We always said it was bad for patients. We always said there was harm involved, but now the risks are even higher and more obvious. So we need to do something that makes it possible to do the social distancing. And I think my last slide is the next one, which was just to say we are a single system. We need to work together more so than ever. We need to be working out how this is going to work for everybody. And thank you very much indeed. Happy to take any questions.
Thank you so much. So if you do have questions for Catherine, Catherine's very kindly said that she'll join us at the Q&A session at the end of this. So if you have questions, please do ping them into the chat function and we will gather those up towards the end and we'll try and answer as many as we can. We're going to move as swiftly as we can do on to Nick. Nick is lead clinician in the Dudley Group of Hospitals, that's Russell's Hall Hospital. It's a fairly big hospital to the west of that central mass of city that is Birmingham, the Black Country, and Wolverhampton, and all of those surrounding areas. And he's going to talk next. So Nick, if you are unmuted, I will give you a warning 1 minute before the end of your talk.
Thank you, Jim. Can you hear me?
We can.
Good. Okay. Good afternoon, everybody. Welcome from the Black Country. The votes from the Dudley jury are as follows. So I've only got the one slide to show you. I don't have quite as many as Catherine had to go through. So I've been asked to give 3 positive learning points, 3 knotty problems, and what we need help with in the future. Now, the first thing that struck me was the way that staff have responded to the crisis. After what we've all been through over the last few years and some of the things I've seen, some of the difficulties that staff have faced, I was really unsure if our staff had anything left in reserve. Well, the answer unequivocally was that they did, or they do. And I'm very keen to see that both within this trust and the wider NHS, that resilience that they've demonstrated is very much nurtured rather than misused, in that they're expected to just carry on through the hard times if hard times are to come. But I think overall that the way that our staff responded has been, to me, the most astonishing thing about the past couple of months. Secondly, the other positive learning point is that what we saw was not a complete breakdown, but a real fragmentation, a real fragmentation of silos within the hospital, both clinical and managerial. I think what this indicates to us is that there really is a huge potential which has been untapped for future improvements to acute care delivery. There was a much more cohesive approach across the whole trust, and I think what this really allowed us to do is to deliver much better, safer care for acutely unwell patients. Then the matter of, thirdly, I felt that what the pandemic has demonstrated is that it essentially acted as a sort of case control study to demonstrate that given flow and proper resources appropriate to the demands placed on the front door, then emergency departments can deliver safe, good care and performance. So again, I think this is a very positive thing in that it shows that given the tools, we can do the job. Some of the knotty problems, well, I don't want to dwell too much on these because I think that overall the experience, at least in terms of the way we've all been able to bring this together and deliver solutions to the issues has been the main theme. But there have been some things that I'd just like to highlight. We have already seen something of a retreat from the front line from certain quarters, which I think is, what we don't want to go back to, as has already been said, is that previous way of working, which, as we all know, didn't necessarily always enable us to deliver the good care. I think staff well-being.
1 more minute.
Okay, staff well-being has required very close attention, particularly with regards to PPE and individual risks. We've mitigated that in certain ways, such as enhanced handovers, and I think that will have to continue for the future. Complexity within the system has increased even further, both in terms of the footprint, the layout, the different issues we've had to deal with. Then what do we need help with in the future? Well, we really need to keep the whole trust engaged at the front door of the hospital when or if the threat of COVID recedes, because it's that fear of the peace that may come, as opposed to the battle that we've been through, that I think is really at the forefront of our minds. Then, as has already been discussed, there's how to adjust to longer term adaptations regarding social distancing, layouts, and just finally to say it's been noticeable how much easier it's been to do our job without all the junk email that one seems to get, and the calls from various departments in the hospital saying, can you do this by tomorrow afternoon? So I think within trusts, minimising bureaucracy enables staff to focus on clinical care. Thank you very much.
Thank you so much. That's absolutely fabulous. If anyone has any specific questions for Nick about any of that, please do put his name in your question on the chat function. We're going to move next to Frank. Frank is Legal Service at Nottingham University Hospital. And Frank, I'm mindful that you have a lot of slides to get through. I will give you a warning at 1 minute so you know that the time is coming to an end. If you make sure you're unmuted, and then the floor is yours.
Thank you. Yes, I wish I had the discipline of Nick. Move to the next slide quickly. Next slide, please. Yeah, so I think Nick's described a lot of the kind of superb examples of kind of collaborative cross-system working that we've seen, with a responsiveness, a kind of an agility, cutting through bureaucracy, and with frontline clinicians leading the charge, I think, which made a big difference. So over the next few minutes, I'm just going to talk to you about 3 things that we found useful in our preparation for COVID-19. So if we move on to the next slide, they are, initially we found that our communication within the department was a little bit disjointed. So we developed an acronym, Speedier Communication, which I described. And, that kind of communication, poor communication, is not what you need in a pandemic. And we've seen that outside of EDs and nationally. We'll talk a bit about how we refined our comms within the department. And finally, I'm going to talk about how we integrated our education and research team, DREAM, which is co-located in a clinical skills area right beside the department. For me, had been a little disjointed and not really linked with the department as good as it had been. And in COVID-19, it did. Another present of COVID-19. Next slide, please. So Chris thought I had some kind of quip for this one. You can put your own caption to it, but it was really just to highlight Speedier Communication acronym, which I'll talk about in the next slide. So the different elements. So Speedier Communication stood for 1. So when we all needed to look at our staffing, how we redeployed staff, how we divided, made rotas for COVID and non-COVID areas, how we engaged with the rest of the hospital for a lot of staff that initially were going to be coming for the worst case scenario surge, but never arrived. And we created a workforce hub. So we addressed staffing. When we would go through this, we would also think about the psychological elements of how we were supporting our staff psychologically. The next 3 elements look at, obviously, with patients constantly at the center of this, we look at our pathways and processes. We would look at our environment, so how we were configuring our environment. And because all of this was changing rapidly, it was really useful to have this template to do it in a systematic way. Most of the equipment was around PPE, but also thinking about moving equipment around the department. The D stood for digital, and this meeting is an example how we've completely changed the way we use IT, both for remote consultation, remote education, and these kinds of meetings. So again, looking at our IT, what kind of computers we needed, what kind of equipment we needed for it. Then we'd address our interfaces, and our main interfaces across the pandemic were with respiratory medicine, acute medicine, HCOP, infection diseases, etc., radiology. So we would look at our pathways across these areas again in a systematic way. And finally, we would address our education and research that was going on. So the next 2 slides. So that acronym we found really useful both for our own meetings, but then when we were communicating to the rest of the department, we would use this template. Next slide. So as I mentioned, communication is really important, and particularly where you're having rapidly changing environment around your next escalations in your department, pathways that would change daily, testing, PPE, we know the kind of debacle we had with PPE and constant changing, and finally rumor and kind of fake news that kind of freaked out the staff. So moving on to the next piece. Well, we've always had issues with communication. So I think Corona was the great unmasker, and kind of really in Corona Veritas is the kind of thing I'd say that we showed how poor our communication was, particularly from the trust downwards to us, etc. So next slide. What we did was tried to funnel all our communication through one COVID group within the department, so COVID executive, and we would then send out messages to the department through WhatsApp messages on a daily WhatsApp briefing. That's the next click, please, Chris. Through WhatsApp briefings, and also through daily messages. We also created an ED COVID-19 email address, so staff in the department could send in questions and we'd reply really responsively within 48 hours. And we're going to continue that with an ED Ask email, which will be similar. So a good way to communicating to a staff of kind of 500 people. Finally, the bit that we really found useful was Dream, so the department becoming involved, and without Dream we would have been lost, because you can put up the next slide, supporting particularly around PPE, education around doffing and donning for other staff coming to ED, supporting the remote education and setting that up for our clinicians to support our trainees and other people setting up remote meetings. And finally, our research team delivered the pre-study with an ED, but also actually took a lead across the whole trust for all the interventional trials that all research staff. So it was a really good profile for ED that we took that lead. Lastly, moving on to the next slide, moving into the new normal, what are the big concerns? I think, again, next click, what we're going to need moving into the future is a really rapid kind of response in the same way as we had pre-COVID, where we've got that kind of cutting through all that bureaucracy in the same way post for the new normal. And I don't think, unfortunately, I'm seeing that locally, and I think that's what's required if we're going to get to the kind of RCEM 5 recommendations. Thank you for your time.
Frank, thank you very much. You whipped through those with great speed. That's brilliant. Any questions for Frank, please do highlight his name in the questions for them. And we will continue to move on, realising that 5 minutes isn't long, to Sarah Service, clinical lead for Sandwell and West Birmingham Hospital, relatively new into this post before COVID started, so he has had a real trial of fire, has done incredibly well, I think, to lead a team through this difficult period. So the floor is yours if you'd like to unmute yourself, and I'll give you a warning at 1 minute.
Thank you, Jim, and thank you for the lovely introduction. My slides are not as pictorial as the previous one, but I'll try my best. I think the first thing which I thought would be useful is to see what our trust has seen as numbers. And I think number of patients we've seen which were confirmed positive were about 1,200 patients. This data is from yesterday, and the patients we were able to discharge successfully was about 65% of the patients, and the mortality was sitting around 28% out of all the patients. And I would say that we'll take pride in discharging one of the oldest patients in the entire UK, who was 106 years old, successfully after treating for COVID. So that was one of a pride story for us. Next slide, please. I think as part of the response, there are a lot of things which come to your mind when you have to talk about, but I kind of picked these issues. So we went through our departments divided into 3 phases of expansion. I think the phase 1 was the initial phase where we kind of just took the hit with COVID. And then phase 2 was more of the current phase we are in, where we are holding on to the numbers. And but going forward, we have looked at dividing the footprints into 2 departments, which is the phase 3, when we'll have the lockdown release and more patients coming in. PPE wise, I would say we've been lucky, yes. I think we started using FFP3 mask and the full PPE in a COVID area, which was quite early in the beginning time when I was reading the messages in the WhatsApp group from my London colleagues, and it was quite variable in other trusts. And the non-COVID was surgical mask. But I think the other success story was a bit of a half mask respirators, which were donated to us by a very generous GP, which was very helpful for our ED department. And swabs wise, I think we are doing 2-hour swabs turnaround now based in City Hospital, which is the other cross site, which has been very useful in terms of the flow of the patients. And for the non-COVID, we are still doing the 24-hour turnaround. The pathways we did agree for have had various conversations with the admitting team where everybody kind of has their own definition for COVID, and that hasn't helped, but we've kind of created our pathways and said ED clinicians are the final say in deciding whether it's COVID or non-COVID, even though we're not the experts completely, but we've seen a lot, I would say. And well-being, the last, well-being, I think, has been one of the factors which we have picked up from the very beginning, knowing the fact that people are in a situation where they've got family members, and the trust have supported us with even providing hotel accommodation and other things for people who are high-risk people. So we've used the RCEM app really well. And then also the trust has recently launched Thrive app and something called Recharge Booth, which has been very useful. I think a couple of other things is in terms of teaching, which I wanted to say is that we've restarted the Zoom teaching for our multidisciplinary teams, including nurses, and that has been taken up really well. Next slide, please. Positive learning points.
So if you've got 1 minute now.
Thank you. I think I've just highlighted the main learning points, which is the peds and minors being streamed out. We've used this opportunity to continue saying that can we use minors in the other footprint outside ED, giving us more cubicles in the main footprint. Senior decision maker having down to avoid admissions has been very useful. And I think yesterday we had a meeting with CCG locally to see if we can start utilizing their slots to avoid admission avoidance and people who come out of hours as ambulatory patients who don't need to be in ED. And mental health services again has been quite helpful with the video conferencing and virtual connects. Next slide, please. Last challenges, I would say just managing the department is the biggest challenge going forward, maintaining both the streams. And I think like Catherine and everybody else has said, having ED as no crowding zone, no corridor patients, and still seeing the pre-COVID numbers is going to be a challenge. And I think that's what we are looking at going forward to having some more support. And lastly, we have used this as an opportunity for the new hospitals being built to have more negative pressure rooms and more side rooms. And we are having the conversation at the moment with the management regarding that. Thank you.
Sure, thank you so much. That's absolutely brilliant. So anything if that's sparked your interest, please do ping in a question and make sure you put the service detail on that and we can identify that with him. I'm delighted to say that Cliff has joined the call. I know he was busy early on, he's joined part way through. I'm delighted to say that he's now here and he's going to spend a little bit of time talking to us and updating us and hopefully giving us some headline information. Cliff, welcome. Please do unmute yourself. We're going to aim to give you just under 15 minutes and I will give you a 2-minute warning at the end so you've got time to wrap up if that's all right with you.
Yes, of course. Thanks very much indeed. So a great pleasure to be invited. So those of you who are on the Zoom call with Catherine and RCEM yesterday, some of these slides you will have seen before. I apologise for that, but I think the data is important, and I know that many people won't have been on that call because they'll have had clinical commitments, etc. So the first is this slide, which is basically showing the pattern of the pandemic so far. This is all familiar to you, but I think it's very important that we understand that the two biggest nosocomial risks, well, the two biggest risks are from nosocomial infection in care homes and in hospitals. And actually community transmission is a very small part of this pandemic. And so the things that exercise the wider media, not necessarily focus on the things that we need to be concerned, which is this massive potential for nosocomial spread and the risk to our staff and to our patients because of that. How do I go to the next slide, James? I just speak and it happens. So this is the breakdown of the pandemic as it goes across the country. Obviously, interesting, the Midlands must be the most heterogeneous area, really, in terms of going from very high levels of COVID disease to relatively low levels of COVID disease. And I'm sure the people on this call would appreciate that much more than I do. But whereas most regions seem to have either be settled on one sort of level, the Midlands is much more heterogeneous than that. And that, I suspect, will lead to some fascinating insights from colleagues about how the pandemic is affecting them at different points in the first wave, at least initially. Next slide, please. So this data shows the pressure on the hospitals is easing. On the right-hand side, you can see that the Midlands is there in the top right, and I suppose from the point of view of regional pride, is second only to London in terms of the way in which the pandemic has played out. It is interesting that everybody's peak was in the second week of April. What is more interesting is how London has fallen rapidly from that peak, and every other area of the country, really, the decline in cases has been much less exponential, if you like, much more linear. Everybody is going in roughly the right direction, though we'll all be aware of the fact that there seems to be a different level of concern in Scotland at the moment, and you can understand why when you look at this chart, which shows that there has been much less of a fall off in their numbers, and their numbers still remain pretty high. This chart on the left is also very interesting because this peaks the deaths above the normal range. So what they've done is we've taken out the COVID deaths here specifically and simply put all deaths in there. And therefore, you can see it doesn't really matter whether these deaths have been appropriately coded as COVID positive or negative. You can see that the spike in above average deaths was indeed the second week of April, continues to be substantially above where it was in previous years. So sitting at about 14,000, whereas the 5-year average for May is closer to 11,000. So there's still about a 3,000 increase per week, but it is definitely going in the right direction. Next slide, please. This data just shows the weekly day-on-day variation in the mortality reported from COVID deaths. These are actually deaths reported as being in patients with COVID actually diagnosed. They may not have died of COVID, but they died with COVID positive status. And as we all know, the number of deaths falls over the weekend due to the reporting cycle and then spikes on the Tuesday. But currently there seems to be a steady track downwards. Next slide, please. This comes from Professor Spiegelhalter at Imperial, and some of the modelling I know is open to criticism, but this isn't modelling. This is simply looking at the death rates for each age group, and you can see that it's most important to understand that actually this is a logarithmic graph. So the y-axis, there's an order of magnitude between each of those lines on the y-axis. The x-axis is age. And what coronavirus essentially does is it's doubling the mortality or the absolute risk of death for every individual in the population for whatever their normal risk would be. So obviously young people tend to die much less often than older people. And the same is true if they get coronavirus. Coronavirus doubles your absolute rate. So if your risk was 1 in 500, it becomes 2 in 500. I think this is a useful way to try and appreciate the level of risk that we're talking about in terms of individual patients. Next slide, please. So this is showing some of the capacity. Obviously, I've shown you the demand side of the equation, if you like. This is the capacity side of the equation. These are ITU bed numbers. It's a couple of days old, but hasn't not much to change in the last 2 days on this. And you can see that across the country, on this chart, it shows that the Midlands has got 345 beds occupied and 382 empty ITU beds across the region. And a similar picture is seen for all areas. The highest numbers currently probably in the east of England, where occupancy is sitting at 56%. But these are historically very low numbers. Some of you will rightly point out that the HSJ was able to identify that a number of sites have much higher occupancies than this, with some of them more than 100% of their previous ITU beds currently full, mostly with COVID patients. So this is regional data. It doesn't mean to say there aren't significant variations within each region, but it does show that the country as a whole has considerable intensive care headroom currently. Next slide, please. So sorry, this is a very busy slide, but all this is basically showing is along the x-axis every week from the beginning of October last year right up to the beginning of May this year. And on the y-axis, the numbers of patients presenting to emergency departments with the diagnoses that match the colours of the lines. So that's stroke, bronchopneumonia, acute coronary syndrome, myocardial infarction, etc., etc. And you can see there are some interesting patterns here with the levels of myocardial infarction going down from the first week of March, but the biggest changes being in the green lines for acute coronary syndrome and the blue line acute pulmonary edema on this. But most importantly, really, is the fact that there was only a fairly short dip in this data. In these presentations, you can see that the presentations are beginning to rise quite rapidly back to pre-peak of the pandemic levels. This is the 3rd of May. We're obviously now on the 20th of May or somewhere around there, 22nd of May. So this data will be updated, but there's a 2-week lag usually in getting data of sufficient quality to be able to put in these charts. But the expectation and the reports we're getting back from the regional clinical advisors is that most of the major presentations have returned to previous levels, albeit we are still seeing delayed presentations of some diagnoses. Next slide, please. So this is looking at data around occupancy of beds and the pressures that we're therefore building in terms of exit block out of our EDs. And at the top, you can see that there's 2 hospitals in the Midlands that have very high occupancy currently. The first is Royal Stoke University Hospital, and the other is the Manor Hospital in Walsall. Sorry, just trying to stop my phone going. Both of which are sitting at around 84%. This is a key concern because neither of those hospitals has returned to their previous levels of elective activity. And as they increase the amount of elective work, that is going to produce massive pressure on those systems, and that potentially risks further queues in their emergency departments, which I'll come on to in a moment. At the bottom, we have got data looking at why patients are in hospital, using the reasons to reside, which you may or may not know about, but this is a tool used or should be used on every ward every day to determine why patients are in hospital so we can move them out in a timely fashion. You can see that unfortunately the vast swathes of the country that are simply not recording this, though the Midlands is doing pretty well, with 75% of patients having a recorded reason to reside. And you're doing even better when it comes to recording where people are actually discharged to, so that we know that more than 95% of the time in the Midlands where people have been discharged to. And this is key information for us moving forward to understand the interface between health and social care and ensure that the previous arguments around health and social care don't return to cause lots and lots of problems with delayed discharges from our hospitals. Next slide, please. So this data has been literally pinched from the bloke who spoke yesterday from Cambridge University Hospital, highlighting a key issue that we need to keep focused on in the next few weeks around the nosocomial problem. So this data basically shows that 3% of healthcare workers probably have the virus, but at any one time and are asymptomatic. And on the left-hand side, the data from the Diamond Princess basically proved that even patients over 65, because most people on a cruise are over 65, so I'm told, 50% of them are asymptomatic, completely asymptomatic. So even on a ship that's riddled with the disease and everybody's very concerned, half the patients had no idea that they were actually testing positive for this virus. So there's a real problem here in us being unable to be sure that the people working alongside us, looking after our patients, are not actually asymptomatic carriers of the virus. Next slide, please. So this is, you'll see that some of this has been basically lifted from the RCEM position statement. Emergency departments must not allow nosocomial infections and they must not become crowded. We must make sure that we can safely care for our shielded and vulnerable patients, and we make the point to NHS England and the Secretary of State that most majors patients are either shielded or vulnerable. Of the non-majors patients, we saw 10 million of those last year, and if you do the basic maths, that works out at an average of 150 per ED per day. And clearly, we cannot possibly manage 150 people in a waiting room over 24 hours with our current footprints and maintain social distancing. And as you've already seen from the previous slide, the risk that some of these patients will be asymptomatic carriers is really very high indeed. So we need to reduce attendance numbers. We need to even out the arrival times of those who do attend where that is safe and sensible to do so. And that's part of the argument behind why we want to promote and expand the role of NHS 111. Next slide, please. So this is rather blurred. I'm sorry about that. I don't know why that is. And I'll sincerely send a much clearer version of this, but just to talk you through it, and I think the important thing in many ways are the colours rather than the actual text. So the green boxes, as you can see, says "We come to you," and this is all about making sure that the shielded patients, in particular, phone 111 for an urgent health need or 999. They do not simply present to an emergency department. If they phone 111 and it's deemed that they don't need to be passed to 999, then we are working hard to increase the options in the directory of service that 111 can access, so that we can have care coming to your own home through a responsive home care service, we can enhance frailty responses to people's own homes or to their community home setting. And if you need to have a one-to-one with a clinician, then that can be done in either primary or secondary care, preferably as a virtual consultation in the first instance, and only where necessary would we move to face-to-face. And if that's in a hospital, then we should promote the notion of hot clinics and same-day emergency care, so that we don't have to admit you to the hospital, and therefore all the time we are working hard to reduce the risk of nosocomial infection to you. If you do self-present, then we would regard that as an unheralded arrangement, and therefore that potentially puts you and others at risk. So whilst people will always be able to present to an emergency department, we want to try and encourage them to, if they contact us first of all, we can keep them and other people safer. And therefore you come to us is amber in terms of risk, as opposed to green when we come to you. Next slide, please.
Cliff, 2 minutes, 2 minutes, please.
Fine. So how will we know when your ED is full? Well, we've taken the data from GIRFT, and you can see that we've taken, these are the pilot site hospitals for the field test, but we've got this data for every hospital. So we know what the number of majors and recess cubicles are, and we know how many people they were putting through them last year. And we can work out, therefore, what 75 or 80% occupancy would be. And therefore, we can start to create trigger points beyond which hospital staff at that site need to create greater flows outside of the ED. This can be done by operationalizing the ready to proceed metric, which was one of the key metrics in the clinical review of standards. And where we're not able to move patients onto the wards in a timely fashion, it will be essential that all hospitals develop and staff a post-ED admission unit, so that the emergency department can maintain flow through the emergency department without creating either delays to ambulance handovers or allowing people to be in corridors, which is unacceptable. I think the last slide is just going to pick up on that very point, that what we're really trying to do here all the time is move to new ways of working, which include being told the patients are coming to hospital so that we can plan for their arrival and keep them safe. And wherever possible, we move them out of hospital in a timely fashion by either completing their care in the emergency department and allowing them to go home, moving them to a same-day emergency care type unit, and when they need to go to a ward, if there's any obstruction for them getting to a ward because of occupancy on the ward, then the use of a cohorted pre-admission unit under the control and responsibility of the inpatient teams is going to be a vital element or piece of the jigsaw. So I will stop there, James, and hand you back.
Fabulous, Cliff. Thank you so very much. That was absolutely brilliant. So Cliff has agreed to stay and be part of the Q&A at the end, and hopefully we'll be joined. So Nick Hall, who's the head of integrated urgent care delivery and part of the 111 redesign and redeploy, will also be is on the call as well. So if you have any questions, particularly about 111 and its delivery, I'm sure they will be able to help. We also have as our local regional person, Pirsha, who is the lead for the 999 111 service across the regional patches on the call. And so any questions particularly around that, please do highlight those and we'll try and pick those up at the end. Right, we shall continue to move on to Catherine. Catherine is the clinical lead in Chesterfield. Chesterfield is a vision of Crooked Spire. It represents a smaller hospital. So Catherine's probably the smallest individual hospital that is going to present to us, but really an absolutely critical voice in the fact that the experience of dealing with COVID disease and the challenges of redeploying staff and redeploying departments can be very different in smaller sites and larger sites. And I think her voice is really, really important. So Catherine, please do unmute yourself. I will give you a minute's warning as you get towards the end, and thank you very much.
Thank you, Jim. I hope everybody can hear me. Is that okay? Can you hear me, Jim?
Yes, we can. Okay,
brilliant. So yeah, just to put the Crooked Spire into perspective, we see about 75,000 patients a year, and we have some challenges with consultant workforce. So we have about 5.6 whole-time equivalents currently, with some extra locum consultants. So I'm really the things that were positive, I'm quite proud to think that as a smallish hospital, we've actually achieved many of the things that have already been talked about and have been talked about on the National Clinical Leads WhatsApp group and over the National Leads Zoom meetings. Perhaps not to the same extent, but we definitely have considered all of them. So the three highlights really were our phased physical changes, and the second phase of that was essentially taking over the existing fracture clinic, which was one of those long dreamed about missions to get some more physical space in a very old department. The other thing to realise is that I've been a consultant there for 20 years nearly, and we've had minimal upgrades to the physical environment over that time period, and rather ironically received agreement from the Department of Health for a 19.2 million upgrade just before lockdown, and actually haven't even shared that very widely within the trust because of everything that has happened. Nevertheless, we took over Fracture Clinic, and within a couple of days had made it into a semi-fit for purpose green emergency department. I say semi-fit for purpose because the doors weren't wide enough to get trolleys through and will probably fall down in the not too distant future. And we have no piped oxygen or suction in that area. But we are managing high dependency standards of care very carefully within Green ED, and fully supported by our ITU and anaesthetic staff, etc., and the medics. To go alongside that, we obviously had to adopt a really clear flow pathway, and that it was crucial that the whole trust understood that EMAS, our ambulance service, understood that, and it seems to have worked. We had great buy-in from our wider trust. We've had lots of support from the orthopods, which was a real surprise, because not only did they move out, but they've provided 24/7 middle grade cover, which is completely new in our organisation. But there are many other parts, mental health, paediatrics, other teams have also taken patients directly from triage to try and enable Green ED to flow. And we also had to think hard about our rota, because of the struggles we have recruiting permanent senior staff, middle grade and seniors. We needed to think inventively about how to staff the two areas, and actually devised a 2-tier rota rather than a 3-tier rota. So the juniors looked after themselves, and we added in some of the junior middle grades to allow them to make a much more resilient rota line for all of them. And then the more senior middle grades joined us as consultants and have stepped up, not necessarily being on call, but have stepped up in every other respect and enjoyed that responsibility. It's allowed us to support them more actively in that learning goal. I have to say, I've added a fourth thing, because we wouldn't have achieved any of this without the communication strands that the trust put in place fairly early on, in terms of bronze to gold communications every day. And that's still religiously happening. We're using WhatsApp and all sorts of other social media mediums, just like everybody else. I'm not going to dwell on the knotty problems because they're common to everybody, I think. But being on the edge of Yorkshire and Derbyshire meant that our swabs were sent at various points to Birmingham, Nottingham, or Yorkshire, or to Sheffield. And that has caused mayhem for us. We've only got reliable in-house testing for some of the swabs that we need in the last 10 days or so. That's been really difficult for us as a trust. And the only sort of local challenge that's been quite difficult is how to keep a fairly large group of vulnerable stroke shielding nursing staff engaged and at work via home, if you like. But we have been quite inventive, and they've started doing some of our coding and things like that. And what do we need help with? Well, I think bearing in mind that our urgent care village money was agreed just before lockdown, we do need to go back to that drawing board. It's going to be quite interesting to look back at the plans that we had and think how we might need to change them for infection control, social distancing, etc. reasons, and how we achieve that within the budget is going to be quite difficult. We've also moved into the space that we were going to use, so moving out again to allow building work at an unknown period. We should have started building already, and that's going to be really tricky for us locally. And the other sort of less global problems, or the normal problems that everyone's going to have, stepping back down to reasonable rotas without losing the benefits of that we've seen. We worked shorter shifts. We might have worked more often, but we improved our resilience by working less hours each time. And things like that are difficult to put back in when you've got few people in the pot.
Catherine,
and that's
I'm
probably
sorry,
all
I'm going to have to give, Catherine, if you can hear me, I just need your very final thoughts because we're going to need to move on.
I've finished. Thank you, Jim. I don't think there is.
Thank you. I'm so sorry. Thank you so much for your presentation. That's absolutely brilliant. I realise that you rushed ever so slightly at the end. Chris, we're going to move fairly swiftly on to you. I'm going to really ask you to whip through with some pace. I've seen your slides. I know that you should be able to do that. So if you want to unmute yourself and start your presentation, that would be fabulous.
Brilliant. Thank you very much. So really, in line with everyone else, our comms has been absolutely key here. Finding sort of the single truth has been absolutely essential. And we opened up comms channels across both our sites using WhatsApp, daily updates, similar to what was happening over in Nottingham. The daily changes in process, what was coming through from the tactical meetings, the gold meetings, the clinical meetings, were all being shared through one forum so that everyone knew that that was the key access for all the information. What we also did was sharing any lessons from simulation. When they were run, they were being shared in real time. And our simulation team were running several simulations a day at times in different areas as we reconfigured the department, as we split red, green, how the waiting room, if someone arrested in the waiting room, for example, was working. And they worked incredibly hard, setting up treasure hunts when equipment had moved, so you knew where to go and look for equipment. And any lessons that were learned, we did a hot debrief, and these were then shared each night. What we also did with our juniors was set up teams. So these have been managed as there was a team leader who was a sort of more senior SHO, who then was responsible for the communication with their team on a daily basis, helped coordinate how they were operating through the red-green. I do have to say we're in a PFI that's only 8 years old, and our estates team have been absolutely fantastic in the support we've been given. Over the process of this, we had 26 new side rooms built, all of which with fairly sturdy looking walls. We've not got plastic that we're using to separate areas. And that's given us incredible legacy really going forward to enable us to keep our patients and staff safe. The doors have all got glass on them. We're then looking to get telemetry to be able to monitor even our majors area, where we've got 19 rooms, we can monitor all of those. Problems we're still dealing with, so the maintaining infection prevention and control while also maintaining flow through the different areas is a problem I think everyone's faced, particularly how we integrate with the different red, green and reconfigure deeper into the hospital. That's something we've been working on and changing regularly, and even next week the process will be changing again, and that's a constant issue we're battling all the time. The reconfiguration of our front door, particularly on the green side, and how we've used our urgent care system and embedded them hasn't worked very well. That's something we're battling with our front door triage, particularly through the green side, and we're still trying to work out how to utilize that effectively. And then the medical staffing, we've been really lucky with redeployed staff, embedding them, giving them educational supervision. But actually, as we look forward, how we're going to react when we lose them is going to be another problem that we have to deal with, and maintaining that 7-day provision that we were seeing at the beginning of the pandemic. What that's going to mean as we change our workforce. Thank you. Going forward, we've got the same issues really that we had before, but they've just been highlighted with the fact that overcrowding, as Catherine has said multiple times, we can't be that safety net. We need to make sure that our GP referrals have somewhere to go, that we can have that out of ED SDEC provision, and that's really how we maintain that with our flow as well. if you're going to be assessed by a clinician, where can you go to have that? I've changed it slightly from internal professional standards to universal professional standards, how we all interact with each other through the system. Everyone has their own stresses from pre-hospital through the organisation to social care and after the hospital at the back door. And it's how we all work through that, making sure that as processes are agreed, we maintain those and keep them going, really going forward. And that is me done.
Chris, thank you so much. That's absolutely fabulous. So if any of that's of interest, please do put a question in for Chris. We shall move swiftly on to Ed. Ed is the clinical lead for Shrewsbury and Telford. So cross far in the west of the patch, keep going along the end of the motorway and then keep going some bit further, and eventually you will find your way there amongst the foothills of Wales. Ed, the floor is yours. I'll give you a warning at 1 minute.
Thank you very much. Good afternoon. At Shrewsbury and Telford, we've had some real challenges. So I came into post just before COVID struck with a new nursing hierarchy as well in the department. So we're a new team working together just as it started, which gave some real opportunities to make some changes and work things out. Across the two sites, we've got a site in Shrewsbury and a site in Telford, very similar size. But we've only got 4 substantive consultants on the on-call rota, so staffing was a real issue. But the real plus to the trust was that the medics stepped up and helped us. So we very quickly brought together a joint clerking pro forma with the medics. And at the Shrewsbury site, the A&E department, the emergency department, took over the acute medical unit. And we combined to one big area with a red side in the medicine side and the green side in the ED, and it's just a one big emergency floor. The beauty of that was the medics stepped up and did very quick senior reviews of all the patients. They're all being post-taked in real time in the department and getting out, and it worked really, really well. As numbers are beginning to step up, we're reopening a green AMU again, and there's some issues with that. But for the first few weeks this has been happening, it's been working really, really well, and it's been very appreciative of the medical support that we've had. In terms of orthopaedics, they also played their part. We've got a specialty orthopaedic hospital in the county at Robert Jones, and they moved all adult trauma from the county to them. So we had no adult trauma being operated on within the trust. That meant that their fracture clinic we didn't take over, they kept it, but they used it as a holding bay to move all the adult trauma out of the trust to be operated on in a separate hospital, which has worked very well as well. So the main positive thing, I think, is how everyone has worked together, and the direct referral into inpatient teams has been pretty good on the whole, but not always working. The knotty problems we've had is the senior medical reviews continuing. As we move on now, they've stepped back a little bit, and then our 4 hours is getting worse as everyone's needing a review in the department, and that's beginning to get some resistance going on there now. Cohorting on wards has been very complicated. We're a very old site, and getting the cohorting right on the wards has been very difficult, and that's meant blockages in the department. And at one point we did have a couple of patients on the corridors on a Monday afternoon with 60% bed occupancy rates, but patients in the wrong place. It was sorted fairly quickly, but it is a difficult problem that we're dealing with. And then moving forwards, one of the biggest things we're going to have is we wanted to keep the early reviews of medical patients by the senior medical team to get the flow going. We've struggled in Shrewsbury and Telford for a long period of time with our 4 hour targets because of flow and because of getting patients to the wards quickly enough. It's been working really well now, but they're beginning to slip back into batching, as we need to make sure that we keep getting the senior reviews early enough in the AMUs, and that hasn't always happened. And specialties are beginning to seep back.
1 minute.
Thank you very much. And specialties are beginning to seep back into seeing their patients in the department rather than on the assessment units. But overall, the real positives has been the staff, the new nursing hierarchy, and how everyone stood up to the challenge. So it's been a very rapid learning curve for all of us, but a very positive one as well. And that's me done.
Fabulous. Ed, thank you so very much. Right, and then the final presentation from one of our sites is from Ben. Ben is representative of Sherwood Forest, north of Nottingham. A successful trust in many respects, has always done very well in their ED performance, and a very highly functioning department that some of us are very envious of. Ben, thank you. I will give you a minute warnings towards the end of your talk.
Thanks, Jim. Very kind introduction. So really want to talk about positive points. It's what really impressed is how fast the trust responded and how fast the social care and other systems responded. So it's fascinating that things we haven't managed to shift for 4 years, exit block and things like that, are done in 2 or 3 weeks. And actually how specialties who sort of essentially really struggle to change their pathways, change them within 2 or 3 days. So that our common goal on the burning platform can actually make a huge difference to change pathways for patients for the better. Been involved in a lot of the trust meetings as divisional lead, and actually what was impressive for us was actually when everyone meets every day for not that long, you can make decisions really fast and act them. And actually someone in the people, where's the governance in this? But the governance is a good conversation with everyone in the room. It's not the meeting with the minuting of the meeting and a separate governance meeting. It's having a meeting that's effective. So we're going to look as a trust how we change that in future, how we restructure, how we move things much faster than the usual NHS bureaucracy that other people have mentioned. After the initial surge and madness of trying to change everything, the lack of other meetings has given us the headspace to make some changes in the department. So actually getting some things sorted that we probably would have been taken months and weeks to sort, we've actually managed to make those changes fairly rapidly, much more quickly than we normally would. And obviously the staff's response has been fantastic. In terms of knotty problems, the specialties, and they have been phenomenal in terms of their response to us, in terms of changing things. It's interesting, as the big tsunami didn't happen, how very rapidly some teams, not all, are rapidly saying, can we go back to normal? And a bit like other people have said, and Catherine said, that actually in lots of people's heads, the plan is to go back to normal. Therefore, all other pathways default to their previous setting, and that's what causes a lot of the exit block and issues with patients. And actually, one of the things we've done as a trust is say, actually, this is, to hate the phrase, this is the new normal. You have to tell us why you're going to go back, rather than the assumption is we go back. But people are starting to really dig their heels in on that now. They start to do that. Real challenge is running the ED, because we've got quite a long, thin department, and then segregating it further with staffing. How do you run the ED? How do you run the separate areas? How do you run it with PPE and segregation? And what we've done is we've separated our resus out. We've made a green resus and a red resus by taking over another area, but that shoved everything further down. And as other specialities are withdrawing their support services because they're going back to elective work, then actually how do we continue to run that segregated areas with other stuff coming back into the ED, so our minors and our peds coming back in? How do we manage the ED in that state?
Ben, 1 minute.
Okay, really quickly. One thing was a mindset actually that someone quoted was the 4-hour target doesn't matter anymore. It's not about the target, it's about crowding. And actually, without exit block, the crowding is mostly down to what we do or how we interact with the trust. So actually getting to the staff and saying we control crowding much more than we did 2 months ago. So we control how fast long people are there. So actually, and the team are responding well to that. Things we need help with, I think capital, how we restructure is difficult and it's costly. The big thing that has to continue is the discharge process from the wards. That's a massive impact on the exit block in the trust, and that it should not cost more to get people out of the hospital, because hospitals are very expensive places to keep old people. So how that stays, and actually how we don't convey people to ED. So the default setting has previously been someone falls over in a home, come into hospital with an ambulance service. How we work better with the ambulance service to not convey people. How we give advice over the phone as an ED, and that kind of thing. But we're doing that work now, and that's continuing. I'll stop there.
Ben, thank you so very much. That's absolutely brilliant. That then brings us to the end of our presentations. I think that's been a real whistle stop across the whole geography of the Midlands, a whole variety of different sorts of hospitals, often with many similar sorts of problems. We're going to move into a short, confess we've slipped slightly beyond our time, but only by a few minutes, a shortened Q&A session for which Chris has been collecting the questions within the chat. Just before we put those out, I'm delighted we've had about 125 people join for the majority of, or certainly big sections of this, and I think that's far exceeds our expectations as to what we managed to reach out to, and hopefully all of you have found something. It may well be more than that, as people have gently found a way of socially distancing, sharing a device and watching it from the same point. And the final little bit of filler from me is that I'm not sure that we made enough of the fact that the Midlands was the #1 region in terms of managing to record where people went on discharge. It's not often that we're top of a list for good reasons. I think we should absolutely celebrate that's the case. Chris, I would be delighted to know if I think we've got time for a few questions. And I know you've been keeping track of them. Do you have a question, a first question? Is it someone specific, or shall we direct it once we know what it is?
Hi there, Jim. Chris speaking. So yeah, we've had quite a lot of chat on the chat, and I think chat isn't working for a couple of people, and so I've had a few by email as well. So everybody else is that our expert panel and Jim and myself have made a commitment that we will get answers for every question that is posed in the chat or I receive via email. So even if we can't answer straight away on the event today, we will ensure that we either signpost or get answers to every question posed, even if that's an opinion of the panel today. So I thought what would be helpful is that there's a few questions that are around the same theme, and to badge them up together. And so generally there's feedback that a lot of barriers have dropped at the beginning and during COVID, barriers that EDs particularly have been fighting for a very long time to drop and not been successful. And there's a general concern about those barriers building up again. And people on the chat have talked about bureaucracy returning that has stopped things from progressing, perhaps in a fast perceived way. And there's also a comment around how do we maintain speciality and manager and executive involvement so that they keep working with EDs? Is there any advice from the panel around how organisations can maintain all of the benefits that COVID has presented to the emergency pathway?
Fabulous. That's a great question, probably a difficult one for us all to answer. I think it would be really interesting to get a couple of different views, and perhaps a view from Catherine as College President might be really helpful, but then perhaps after that we'll come to some within the region, perhaps within the operational side of the region. Charlotte, I know that you're on the call. I don't know whether perhaps you'd have something to add to that as well. Catherine, do you have any feelings or view on
first thing I've got on
how we engage?
The bureaucracy thing is also very interesting. GPs have seen they say a 27% decrease in the amount of admin and bureaucracy that they normally have to tackle, and that this has freed them up by getting rid of that. That's freed them up to be providing a lot more care. So I think there is a national conversation about the amount of bureaucracy that there is in the NHS, and can we cut through that? That's the first thing to say, that I think there's a bit of a wave to try and see how we can improve on that. How do we maintain all the good stuff? Well, in a way, it's trying to influence all the people who see the advantages of the good stuff and try and help people who might be desperate to go back to their old worlds from just heading straight back there. The problem is that there are a lot of people who I think whose worlds have been really changed in the way they've been practicing or doing things, who are fairly desperate to get back to a more normal regime. And I think we have to appreciate that they're worried about backlogs, they're worried about patients that have not been diagnosed with things, they're worried about getting training for their trainees on procedures or whatever it is. But I think it's trying to maintain a open-minded conversation about what were the positives about the way patients have been managed, and steer everything to be around patient care. This was good for patients, therefore how do we carry on doing it, and see if we can get that through. But it's going to be tough, because I think there are a lot of competing pressures on a lot of people.
Catherine, thank you very much. That's brilliant. And Charlotte Aston, I know you're here somewhere. I don't know if you'd like to unmute yourself, and whether or not you have a sort of feelings about that particular question.
Yeah, thanks, Jim. So I think to echo what Catherine said, the patient focus is always a really good way to have these conversations. I'm probably going to get shots at here as the regulator about to say this, but as you know, a body of clinicians and senior individuals, I would start to push back as to why. if the bureaucracy starts to creep back in, actually we've proven that it's not a good use of our time. We can better utilise our time for patients and also staff wellbeing as well. So why do we need to impact and put this process back in? So I would really use, a lot of senior people on this call to push back. And I think we'll certainly take it away. And there's a number of national colleagues on this call as well about how we can gain assurance without over the top killing and the amount of bureaucracy we put in. And I think it's a really difficult balance. We do have to have a level of understanding, as do your executive teams, of what's happening and knowledge that things are safe, etc., but without creating that sort of ongoing workload that just churns, that doesn't really deliver. So I think we'll take it away. But it'll be interesting to learn and see how we come out over the coming weeks, but why the challenge would always be a good one for me.
Fabulous. Charlotte, thank you very much. I think that's two responses to a question that we could probably spend an entire day exploring in its own right. Chris, do we have, I think we've got time for probably one more. Do we have an appropriate second question?
Yeah, I mean, we've got loads of questions coming in now and comments, and thankfully some of the panel are picking them up on the chat function. But just to reiterate, any questions you put on that chat function after the event, we will ensure gets a response or an answer from somebody within the expert panel. So a couple of questions on email and on chat are around the same subject. Cliff, it's more directed towards Cliff, who has got a keen interest on the future usage of things like 111 and how whether he has any thoughts around what could be the future of 111 usage to support and maintain the traction that we've had through COVID.
Yes, so certainly happy to take that. I think the key thing about 111 is it's part of a range of solutions that can be brought to the problem of crowding, and it's a key enabler of ensuring that we provide a better service to patients 7 days a week and for many more hours of the day. So the key thing is that 111 lacked before the pandemic was a national clinical reference group. It's now got almost 1,000 clinicians working at a national level where calls can be diverted to them, and so much more bespoke advice can be given, particularly to complex patients with comorbidities, rather than simply being a primarily algorithmic approach to healthcare. And I think the other thing that we can all do to support it is that it was no fault of the 111 service that the directory of services to which it could refer into was largely empty, particularly at weekends and out of hours. And many of the secondary care services had previously said that these things couldn't be done or weren't appropriate. But in the last 2 months, we found that suddenly they have realised that you can both deliver and actually succeed with remote TIA clinics. We have hot clinics, we can have same-day emergency care, and a whole range of problems that previously they said that there was no demand for or no ability to deliver. They have actually found there is both a demand and an ability to deliver. So it's incumbent, I think, to pick up on a theme that the college has been pursuing under Catherine for some time now, is that it's not acceptable for emergency departments to be a safety net for the services. It is perfectly acceptable for it to be a safety net for individual patients. So when people set up a service, whether that's a gastroenterology service or a highly specialised tertiary referral service, what is their plan for out-of-hours care for the patients that they look after and for whom unexpected events are bound to happen? And that cannot be, well, you just phone your GP and or pitch up at the emergency department. We need to hold them to account on that and demonstrate that the opportunity to interface with these specialist services extends beyond Monday to Friday 9 to 5. As I have previously said, and I don't wish to be glib, if you're only running a service Monday to Friday 9 to 5, surely that's a paid hobby. A service means that it should be some sort of commitment to how you can look after your patients in crisis 24/7. That doesn't mean to say you yourself have to do it, but you have to be part of the design team that puts together a credible service specification to enable patients to access that. And these are the sorts of things that 111 would love to be able to direct people to and refer them into if only they were available. And we hope that because we've demonstrated over the last 2 months that these things can be made available, that we should continue to do it.
Okay, thank you. That's brilliant. We're perilously close to the end of our session, and so I think this now leads us to sort of the ending piece. I think this has been a really great afternoon. Chris, can I have the next slide after this, please? I think what we've seen described is the fact that all of our departments are slightly different. They've all had very similar endpoints, but their route of getting there has been somewhat different. And one of the key features to us learning from this is understanding that our experience of COVID will not be the same as the department down the road or the department across the county's experience of COVID. But theirs is no less valid and theirs no less than important. And I think that's been why it's so critical. We've had a broad range of people speaking this afternoon about their experiences. Next slide, please. For so long, I think, in an emergency department setting, we've seen the slow progressive change to our services that's made it a bit tougher and a bit tougher and a bit tougher. And we've rebased ourselves and we've got used to the conditions that we're working in and perhaps the crowding or the volumes of activity that we're seeing in front of us. And each time we've got used to it and we've started afresh and we've rebuilt our services and redesigned our services. But each time we've redesigned them, we've perhaps seen ever decreasing returns in what we've managed to achieve. This does feel like there's an opportunity to really reset a sort of a new way of delivering our care. Next slide, please. But within that, we're going to find that we're going to make changes and we'll regret them or we'll find them difficult or we'll find that the change that we've made is then hard to live with until we get used to it and we refine it again and we build upon it. And even those of us who have taken services through endless change and endless redesign will find that we still make mistakes and we still do silly things as we're developing. Next slide, please. There are a million different drawings of how you get from one position to the next. The reason I've put this one in is that on a number of occasions through this pathway, we describe reflection. And I think what this afternoon has delivered us is our first opportunity to reflect. We've collected some thoughts, we've collected some information, we've collected a view on all of the things that have been good, all of the things that have been difficult, the things we want to keep. And this reflection will be so important to us in making sure that the services we then go on to run will be absolutely the right ones. And final slide, I think, Chris. So the last part of this is for me to say thank you. Thank you to all of those who've presented, to Catherine and Cliff coming to represent the national stage and to share your thoughts and insight. But almost more importantly to all of our local sites who've put themselves forward and they have volunteered themselves to come and present their experience of redesigning their services at great speed to deliver care through this pandemic period, and then to start to understand what that's going to mean for them after this. So I'm delighted that we've had so many people join us. I'm thrilled that our reach has gone beyond that we expected it to be. And I really do hope that this is the first of several meetings of this sort where we share the learning that we've got from COVID. The slides and the video from this will be available in about a week's time. And as Chris said at the outset, we will endeavour to look at all of the questions that are put forward and will attempt to deliver answers to all of those as quickly as we can do. But I'd now like to bring this to a close. Thank you so very much for listening, and we really do look forward to doing this again in the future.